Thanks. Hi, everyone. You get to hear from another general pediatric surgeon. So now we're going to talk about the intestines. And can we get my slides up? Oh, I see. Sorry. So I just do that. There we go. Okay. So intestinal rotational anomalies, this is the umbrella term for what we're going to be talking about. Everybody thinks about it as malrotation, but malrotation is only one element of an intestinal rotational anomaly, and that's what I'm going to try to convey to you. In general, they're rare, and they tend to be a little more common in male, but for reasons that are a little unclear. They happen with all sorts of conditions, but predominantly things that are associated with the intestines or the guts developing outside of their normal location. So for example, congenital diaphragmatic hernias, gastroschisis, and fallacy, by definition, these are entities in which the intestines are somewhere else where they shouldn't be, and therefore they don't follow the normal path of migration that we're going to talk about. And quite common within these elements for some congenital heart disease, is particularly the topic at hand today for heterotaxy. So the way the gut normally rotates is outside the body for the first few weeks of life, and then comes back into the belly roughly around the 10th week of gestation. And you have to think about it as sort of two loops, what they call a proximal or duodenal-jejunal loop, which is sort of like the proximal bowel, or the distal cecocolic loop, which is the hindgut or the sort of distal bowel. And any problem in that rotation, even partial or complete, is going to create a problem in what we call the rotational anomaly spectrum. The one that's more sort of thought of is this one, right? This is intestinal malrotation. It's actually a non-rotation of that first loop. That duodenal-jejunal loop stays sort of straight and down to the side, but it's an incomplete or abnormal rotation of that distal loop that sort of doesn't completely rotate, stays kind of somewhere in the mid-abdomen, but generates these adhesions that are called Ladd's bands that are going to partially obstruct the duodenum and also create a pedicle that is very narrow and predispose it to twist. And so this is sort of that presentation where, because the pedicle of the small bowel is narrow, it allows it to twist a little easier, and this is what volvulus is, right? So these bands can also cause obstruction without volvulus, and this can be symptomatic in terms of feeding difficulties, inability to tolerate gastric feeds, etc. So the other end of the spectrum, which can happen as well, but can tend to be a little less symptomatic because the mesentery is not as narrow, is this complete non-rotation, right? So the small bowel is all the way to the left, the cecum and the large bowel is all the way to the right, vice versa, sorry, on the screen here. But essentially this is not impossible to have a volvulus, but a lot less likely because that mesenteric width is a lot wider, and usually don't have Ladd's bands, so these tend to be not as symptomatic. So how does it present? Typically the call is the nurse or the parents say, hey, this is really abnormal green stuff on the bed or the blanket, and it's very green, right? This sort of bilious vomiting in a baby, that's always abnormal. So the typical course is a contrast study, a presentation to the ER, or if it's in the hospital, then that's the next step, which would show some sort of obstruction of flow sometimes versus also basically the bowel staying all on one side and not crossing the midline. There's some radiographic criteria, though now, as I'll show you a little bit later, there's a little more interest in using ultrasound to look at some of these features. And so I think that's some of the things that are coming down the road. We would take this child to the operating room and find something like this, basically a twist of the bowel over itself, where we would untwist it. And this bowel actually looks quite healthy, very pink, not dilated. We got quick to this one. This was an important case where prompt recognition of the problem and expeditious treatment in the OR led to not a problem. So we untwist it, we assess for perfusion, and if there's anything that's concerning, and sometimes they need a bowel resection, sometimes they need a second look, exploration for additional resection, particularly the bowel's not healthy. But in general, if it's caught on time, it's fairly straightforward to fix. It follows the guidelines of Dr. Ladd, who started and stayed here in Boston for a long time. And basically, the procedure involves dividing these Ladd's bands, widening the width of the mesentery. It used to be advocated to remove the appendix, more so because of the diagnostic uncertainty of, well, the appendix now it's going to be in a different location. We should probably just remove it so it doesn't create confusion. But that is, I think, less and less being practiced nowadays, I would say, particularly if it's a child with complex conditions and other issues that may have constipation, may need their appendix for bowel management programs later. So it's not totally required now to remove the appendix, particularly because diagnostic imaging and clinical determination of appendicitis is a lot more straightforward nowadays with modern imaging. However, it does carry, because any abdominal surgery creates scar tissue, it does carry the risk of additional obstructions down the road, not from the initial problem, but more so from adhesions from the surgery. So that can be an issue. And although you remove the main issue, you don't completely restore normal rotation. You convert somebody from malrotation to non-rotation. And so they technically can still have a volvulus. It's less common, but it can happen. And they will always have this sort of non-rotation status. So that's an important distinction to talk about, and also to counsel families about, that they can still present a lot less likely, but they usually have a more wide mesenteric width that helps them prevent that. So the scary situation that we all try to prevent is this situation: a child that looks ill, you get an x-ray, kind of just looks terrible. You go to the OR and it looks totally dead. And so these are kids that really struggle and have high mortality and can have short gut from having to lose a lot of intestine. So really trying to prevent that. So that's like the general elements of intestinal rotation anomalies in the general population. Now, how does it play into heterotaxy? There's definitely some challenges here because the diagnosis is not straightforward because of the whole difference in the sidedness of the organs that can occur here. Sometimes the criteria for the definition are a little bit obscure and not totally applicable, particularly when you have this sort of right-sided stomach situation. Some of the symptoms of feeding difficulties, intolerance, some emesis can overlap sometimes with some of the comorbidities that are associated with intestinal rotation anomalies. And there's a bunch of controversies. I'll show you some of the data. Whether do you screen for malrotation or intestinal rotation anomalies? Do you do prophylactic last procedures? What do you do if you need to put a G-tube in this child? Do you also look for that issue? And if so, do you treat it at the same time? So there's a few other curveballs that come into play. The historical perspective is this one. This actually came out of our group here in Boston a while ago. It looked at just outcomes after lab procedures in patients with heterotaxy. And, small groups, but still very reasonable. 31 kids on one side, 51 on the other. They compare just general outcomes. The table's probably too small for you to kind of focus on. But the bottom line is this, that they found that if allowed to develop abdominal symptoms, about a third of heterotaxy patients with intestinal malrotation had midgut volvulus. So that kind of raised everybody's eyebrows and says, oh, geez, if a third of them are going to have volvulus, geez, we should probably do prophylactic procedures on all of them and screen all of them, right? And so I think the pendulum swung from that, and we all nowadays say, really? Now should all of them get screened? And there was a lot of controversy. I think the survey that followed that a few years later, both surveying cardiologists, cardiac surgeons, general surgeons, there was definitely a bit of a flip of a coin, as you can see. Not everybody agreed. Some believed in one thing, some believed in the other. It was all over the place. And so that led to different practices across everywhere, basically, and came with additional data over time that some centers that just manage these patients expectantly, for example, 414 patients, only one of them developed symptoms attributable to intestinal rotation anomaly. And they also found that complications and mortality sometimes from the actual intervention was not negligible. So some of these suggested that it really wasn't necessary, right? More and more data showed that, hey, geez, actually these kids are high risk for post-op complications, for shunt failures, particularly some of the more delicate kids in the early post-operative period had high risk of shunt failure. So this really kind of swung the pendulum to the other side to say, okay, we really shouldn't probably be doing all of that. This other study looked at 649 patients where about a third underwent a LATS procedure, but really only about 1% had a volvulus, right? And complications, 10% of small bowel obstruction from adhesions from just being in the belly. So again, were the complications greater than the benefit in this setting? More and more, looking at it from a different angle, this group more recently said, okay, of all the kids that have malrotation and undergo a LATS procedure, what's the issue? And you can see clearly that all these complications, surgical site infection, sepsis, thrombosis, prolonged mechanical ventilation, were greater when performed on heterotaxy patients. So it became, again, the same sort of theme, right? This other study is interesting because this is sort of a contemporary cohort out of Arizona where they tried to follow the expectant management but still sort of screened everybody. So they had 18 kids, shorter cohort, but really had a nice protocol as to, okay, what are we going to do? If they're symptomatic, then they get testing, and that's pretty straightforward. If they're asymptomatic, they would get an upper GI just to know, but then they would only intervene on if symptomatic, and they would follow them serially to see who became symptomatic. And they really saw that the majority of these asymptomatics, even if they had a high proportion of intestinal rotational anomalies, they really didn't need surgery. A few of them had feeding intolerance and underwent surgery for G-tube or something else with concomitant LATS procedure, but only a few underwent surgery for volvulus. Actually, only one of them actually had volvulus. So a small proportion. So they really emphasized this point that the screening or the imaging really didn't really inform the decision to do surgery in an otherwise asymptomatic child. So the recommendations from society guidelines within pediatric surgery is that there really isn't any evidence to support screening in asymptomatic patients. And so that's kind of our practice here in Boston. In many places, I believe that's the latest. What I mentioned earlier, just to kind of get closer to wrapping up here, is something that we're going to start to probably look at our institution. There is more and more data from the ultrasound and radiology department that now they're looking at, they used to look only at the relationship between the SMA and SMV, and if you saw a twist or an abnormal relationship with that, then you would say, okay, that's a volvulus, that's a twist of the mesentery. But now they've been a lot more looking at the position of the duodenum, because you can see the duodenum even with fluid, so it's kind of like a contrast upper GI ultrasound where they put fluid in the intestine, usually through either feeding tube or letting the child drink something, and they can see really clearly the duodenum in between, if it's retroperitoneal or not, in between the aorta and the SMA, and if that's the case, then that's by definition not an intestinal rotation anomaly. And they have pretty high sensitivity and specificity, and it's starting to become something that several centers have gone to as a default screening method. Now, this doesn't change the practice of do you screen asymptomatic patients, but when somebody is symptomatic of some sort, whether bilious emesis or just this kid spits up, doesn't tolerate the feeds, or is intermittently in discomfort, is he one of these kids that may be symptomatic? Ultrasound's going to probably, my guess, in the next few years, become a lot more relevant for these evaluations. So to summarize, malrotation is common in heterotaxy. However, symptomatic malrotation and volvulus is super rare. LATS procedures do carry some morbidity and mortality risk in this delicate patient population, so therefore they're not really indicated if the child's asymptomatic. Likewise, screening only, I think, adds confusion and anxiety to the family and to the providers too as to what to do with this information, particularly in an asymptomatic child. We talked about how ultrasound may become more and more popular for some of the screening situations, and really educating families about the symptoms to look out for and having a pathway to evaluate these children is important, particularly when it comes to if they're going to have a feeding axis, right, a G-tube, a GJ tube. I think an important conversation at that point in time is to have an evaluation intraoperatively of that width of the mesenterium. There's really obstructive LAD bands, so sometimes that can be addressed at the same time and may actually convert a child who you thought needed a GJ tube to somebody who just needs a G-tube, because actually the reason why they're not tolerating feeds in the stomach is because there's obstruction in the duodenum from these LATS bands. So we've had a few of those. So that's that. Thank you for the invitation, and we'll be taking questions later. Thank you.